This is an introduction to the SMV surgical simulation model, developed in collaboration with WetLab Inc. A representative surgical procedure will be demonstrated. Please conduct the simulation in accordance with your institution's standard approach. The pedicle of the ileocolic artery, ICA, is grasped and elevated using the assistance forceps and the fourth robotic arm. The peritoneum on the caudal side of the vascular pedicle is incised, and dissection of the mesentery is initiated. The assistance forceps and the fourth arm should be adjusted as necessary to optimize the surgical field. Vertical dissection of the mesentery exposes a characteristic dorsal areolar layer. The incision is extended toward the small intestine, and jejunal branches encountered are divided. Dissection and mobilization of the mesentery are carried out while making full use of the assistance instruments. Mobilization is continued along the dorsal aspect of the mesentery. The fourth arm may be repositioned as needed to maintain optimal visualization. Dissection begins around the superior mesenteric vein, SMV. An artificial areolar plane has been incorporated around the vessels. Perform gentle dissection along the venous wall. Utilize both sharp and blunt dissection techniques to separate the surrounding tissues. Handle lymphatic and connective tissues with care to preserve integrity. On the dorsal side of the mesentery, dissect the plane between the mesentery and the duodenum to facilitate further mobilization. Fine vessels overlying the duodenum can be visualized through the transparent mesentery. Dissection continues along the right border of the SMV. In this model, the superior mesenteric artery, SMA, is located just to the right of the SMV. Therefore, the anterior plane of the artery is also exposed during the dissection. The boundary of the dissection is defined along the left border of the SMA. Nerve fibers are present around the SMA in this model, and caution must be taken to avoid injuring them. Cranial dissection along the anterior surfaces of the SMA and SMV allows identification of the roots of the ileocolic artery and vein. The tissue around the ICV is carefully dissected, and the vein is divided at its root. The origin of the ileocholic artery from the SMA trunk is then confirmed and prepared for division. Dissection is carried out in the region corresponding to lymph node station 203. Keeping the anatomical boundaries in mind. The space between the ileocholic artery and SMV is dissected, the ileocholic artery is encircled, and the artery is divided at its origin. With coordinated use of the assistance forceps and the fourth arm, the mesentery is elevated vertically, and dissection proceeds along the retroperitoneal interface. Both sharp and blunt dissection methods may be explored to evaluate different mobilization strategies. The pancreas can be identified medially, beneath the inner side of the duodenum. A push-up maneuver using the fourth arm can also be effectively applied at this stage. Once adequate mobilization has been achieved, dissection continues around the central vascular structures. The anterior surface of the SMV is dissected further, followed by exposure of the anterior plane of the SMA to refine the dissection boundary. As dissection progresses cranially, the middle colic artery, MCA, and right colic vein, RCV, come into view. Dissection around the MCA root allows identification of its branching pattern and the dorsal ascent of the middle colic vein, MCV. In this demonstration, the MCA is divided at its root, but depending on training objectives, it is also possible to trace the MCA to its bifurcation, divide the RCV at its root, or continue mobilization of the mesentery as desired.